So, uh, I've been pretty involved in my local province and even in some ways nationally on pushing back against some of the governmental policies that occurred throughout the pandemic. So throughout this time, I've done a lot of thinking about what I would have done differently, what I would have want governments to do differently over that period. And and mostly it's about trying to figure out what to do for a future event because in some ways we got away with a pretty minor, uh, I mean, that's not really the right term. It could have been worse, I think is what I'm trying to say. We had about a case in fatality rate of about 1.5% through the worst of the pandemic. But there are, many events in society, the Black Death, cholera events where the case and fatality rate is much, much higher. So, you know, what would happen if we were to have another pandemic event and how would we be better prepared? So when I finally got a chance to read the big one by Mike Osterholm, it really helped me to understand some of the thoughts that I've been having, and it paralleled a lot of my thoughts. And so it was, I wouldn't say our Venn diagram was a complete circle, but it was pretty damn close. And so in the lack of having a good, robust scientifically based inquiry to guide us in the Western world going forward, I feel like this book could give us a framework that we could use going forward. And that's why I invited Mike to come and talk today, because I'm like, your ideas need to be out there. We need to be talking about this so that this just doesn't fall by the wayside. So we don't repeat the mistakes of the SARS-1 event for the SARS-2 event. So I'm going to take some time and I'm going to go through some of the thoughts that I have along with Mike Osterholm. So who is Mike Osterholm? He's an epidemiologist based out of the University of Minnesota. And I really want to highlight that he's the founder of an organization called CIDRAP, which is the Center for Infectious Disease Research and Policy. And they've been I would say, very robust. One of the WHN's favorite speakers on some of these topics is Lisa Brousseau, who's also based out of that institution, and you can really trust what comes out of that institution. And so he has been really center to that. He was on the Biden Pandemic Advisory Committee back in 2020, and he's been really an important voice all throughout the the last 20 years in regards to infectious disease. So really what I'm trying to say is he's much better. He has much more credentials than I do. I am the classic armchair epidemiologist. I just want to confess I have no public health training. I'm not an epidemiologist. I'm an emergency physician who happened to recognize that masks were an important component of a pandemic response. I was vocal on that from the beginning. I helped to do some organizing and create some organizations around that. And I've been lucky enough to be invited to be a part of the WHN to continue some of that work over time. So, all right. And I'm hoping you can see all of this. When it comes to developing policy to protect people in a pandemic, there's really a balance that needs to be found. Because let's be honest, if things are bad and we tell everybody to sit in their basement and not come out for 6 months, we will completely eliminate transmission of that disease. But the question is, at what price? So there is a balance that needs to be found. So on one side, we're trying to save lives, protect healthcare, protect society. And on the other side, we're trying to maintain mental and social health, support families, and support the economy. And I know sometimes people poo-poo the economy, but it is people's livelihoods. Like if you have to close your restaurant because nobody's coming to your restaurant, that's going to impact not only the owner of that restaurant, but the people who work there. And so these do have impacts on society. We do need to find some kind of balance. And on the other hand, if we just say let her rip everybody go out there, everybody support, go to your local restaurant because they're suffering, we're going to be too far on the other side. So these are the two things that we need to keep in mind when it comes through making these policies. So when I think of what needs to go into a good pandemic policy, we kind of need to look at these factors. Does it work? Is it effective? Is it efficient? Is it worth the cost? Is it acceptable? Will people actually go through with it? Is it maintainable? How long can they do it for? And timing triggers, the other word I've been using here is thresholds. When do you implement these policies and when do you take them off? So in the big one, there's, I believe, 8 chapters in there, but I'm going to pull out 7 of the themes that I feel that were really important and that I wanted to speak on. The first is airborne transmission, then personal protection, then indoor space protection, testing, surveillance, vaccines, medications, thresholds, which I use here as triggers, and communication. And so we're going to kind of go through all of these, and then I really want to have a robust discussion as to where Mike's thoughts and my thoughts might be wrong, where they might be right, where we need to put more emphasis. So airborne transmission. Mike argues, and I think effectively, that airborne transmission will drive the next pandemic. Oh, and before I go into this, I want to put one more, um, if you haven't read the book, one more element to his book. He posits that there, kind of as a thought experiment, a new scenario where there's another pandemic. This pandemic follows on the SARS-CoV-2, and he calls it SARS-CoV-3, because he suggests that coronavirus is very likely to be one of the next pandemics. Influenza would be the other possible cause, and that in this imagined scenario, there's a 10% case fatality rate. So it is actually about 7 times more deadly than the last pandemic. And so that's why he calls it the big one. How are we going to prepare for the big one? Um, and so using this thought experiment, he walks through the various policies that occurred during the last pandemic and how we might implement them during this next upcoming scenario. So airborne transmission, he argues, and I think effectively argues, that it's likely to drive this next pandemic. And there's 2 bases to that. The first is that all the other things that cause pandemics, we've actually fixed in many ways, aside from the air. So if you think about cholera, we actually in the Western world have very robust water sanitation programs. In terms of bubonic plague, we actually don't have rats with fleas on them running through our streets, and the crowding that was associated with the bubonic plague. But we haven't really fixed our indoor air. And so that's the vulnerable aspect of our society that would likely allow a new pandemic to come through. The second element of this is that airborne transmission is a very efficient way of transmitting. Everyone knows the classic measles that has an R of 17. I don't think SARS-CoV-2 ever got to like an R of 17. Just a reminder that R means how many people one infected person will go on to infect. Um, but it's definitely an R, that would allow for exponential growth because, when we think about the alternative hypothesis, for SARS-CoV-2 transmission, which is contact droplet, really you can't sneeze over enough people in a room to get that R up substantially. You can't cause enough virus to go into that bowl of chips at the center of your family gathering so that everyone would get the viral infection from the contact element. So airborne is the key. And so if airborne is the key, that means we really need to be robust in preventing that infection. And one of the things, and I mentioned this, I think in the chat yesterday or the day before, is that there's been some really bizarre resistance to dealing with airborne transmission in our society. And I think maybe we need to unpack that a little bit later on in the discussion. I engaged with an organization called the Pandemic Action Network, and they were really involved with that pandemic um, uh, one of my treaty that was being proposed a couple of years ago that eventually ended up failing. But that they were very, very focused on identifying what pathogens were out there, but had zero interest in dealing with the transmission. And I couldn't understand this because what's the point of early identification of a pathogen if then you just let it rip entirely through society? So when you look at another bug, this is a stylized version of syphilis. You can imagine that if you got the transmission of syphilis wrong, you would be unable to prevent syphilis from running through society. So if you were to say, okay, we have an outbreak of syphilis in Alberta at this moment, we need everybody to stop kissing. Um, you know, you you're kind of right. Like syphilis has elements of mouth to mouth contact that because it usually moves on to other things, but it's really sexually transmitted. So unless you solidly identify sexual transmission as the cause, you will not stop a syphilis outbreak. And similarly, with any kind of airborne transmission, if you kind of get it right by saying it's contact droplet, you will not successfully deal with the airborne scenario. So that's where we come to masks. Um, Mike is adamant, and I think accurately so, and I think probably everybody in this room understands that respirator masks are the gold standard of protection. And when we go back, I'm just going to go back a couple slides to this um, picture. There's two kinds of airborne transmission. There's the close contact, which you can see on the left hand of the screen, and the long distance transmission that you can see happening on the right side of the screen. And we're going to talk a little bit about cleaning the air, but cleaning the air does an effective job at preventing that long distance transmission, but doesn't do a lot about this near contact transmission. The only thing that can prevent that is a good mask. And these respirator masks are designed to prevent transmission. And I don't remember any public health statement saying that this is where people should go. In the United States, there were recommendations for respirator masks. In Canada, the Public Health Agency of Canada for a long time used the term wear the best fitted, best constructed mask possible, which only describes a respirator. But for some reason, they were really reticent to use the term respirator. And as we know, when it comes to public health, you have to be clear with people. People don't innately know what an N95, FFP2, FFP3 respirator mask is unless you kind of hand it to them on the plate. And they refuse to hand that to them on the plate. And again, we can talk about why that is. But his recommendation, and I strongly believe that if we had universal respirator mask use in a pandemic, we would markedly drop that transmission and maybe drop that R naught below 1, which would allow transmission to exponentially decline rather than rise. And so this has to be the foundation of any acute response to a new pandemic. And so you may say, well, how can we possibly get everybody to wear these masks? They're expensive. I'll just remind everybody that in World War II, every single person, including kids, were given a gas mask in the UK because there was a fear of chemical attack from the Nazi Germany, and it was just considered to be the minimum that they could do for the populace. And this is a very expensive piece of equipment, and an N95 respirator or an elastomeric respirator mask is not. So the next thing I want to talk about is schools. I think, and I would suggest that that others have thought that schools are one of the important niduses for community transmission. This is really underlined for me when I read a book called The Premonition, who was written by the same guy, and I'm going to forget his name. I'm sorry. Who wrote the big short, the famous movie about the 2008 financial collapse. And he says that the Obama administration and the Bush administration's experts had said that schools are the niduses. This is where it all comes from, and there's been evidence for that since. Now, this is a very controversial topic because schools play an important role in society. Number one, they educate our children, and we want our children to be smart, robust contributors to society as they grow up. And so if they lose part of their education, that is a huge impact. And secondly, it allows parents to be a part of society, to be a part of the economy, and go to work and do things. And so it has this kind of dual role that has made it a target for people saying we shouldn't have had those closures. Now, I just talked about how great respirator masks are. Nobody ever tried to do universal respirator use in schools. And so this is a bit of a thought experiment. I can't say there's a huge amount of evidence for this, but I would posit that if we actually had a universal respirator mask mandate in these schools, it would make a huge difference. And I just want to point out that schools aren't special because kids are especially good viral transmitters. What the reality is that there's very few aspects of society where people, any person of any age, are 40 to a room, elbow to elbow for 8 hours a day. And so that makes these spaces very special, not only for the transmission, but also for trying to protect those spaces. Now, I'll just point out that this is a point of contention between Michael and my ideas. If you read his book, he's very adamant that he says we cannot protect these spaces. And he specifically says that kids can't wear masks. And I disagree with him. I told him that, and he actually, I think, came around. His point was he didn't think there were any N95 masks that were designed for kids, and therefore, because N95 masks are such a key component of transmission mitigation, that if we don't have masks for little kids, then we can't expect them to wear them. But of course, we do have masks for little kids. At least in Canada, there's some really amazing small scale masks that are available. And I think anybody who's had a kid, a lot of us had kids that wore masks all the time in schools. And I would posit, especially in his scenario where there's a 10% case fatality rate, if it was that bad, kids don't want to bring diseases home to their parents, possibly kill their parents, possibly kill their grandparents. They are intelligent, they can be trusted, and I think if they're taught how to wear a mask, they can do it. The hard part is, of course, the indoor spaces where they have to take a mask off, say like a lunchroom, and we're going to talk about that because there are ways we can mitigate those spaces, not perfectly, but we can certainly do better than what we're doing now. So in indoor spaces, we do have the ability to improve ventilation, improve filtration, and put in far UV disinfection. And not only in schools should this be happening, but any public spaces, including movie theaters, restaurants, workspaces. And so, whereas at the very beginning of the SARS pandemic, it wouldn't have been possible to put all these things in place in March of 2020, and the masks would have been holding the majority of the weight on this. As time flows, we do have the ability to put in some of these more robust long-term safety mechanisms in indoor spaces. Testing. So testing arguably was underused during the pandemic. Anybody who's in the UK, I think testing was much better done there. But you can imagine a scenario where testing was overused. Say you did it during a period of high transmission and you test it every 3 days with the effort to try and find those asymptomatic cases, that you would be able to identify people that were at risk. And in particular, in advance of public events like weddings or conferences. Certainly in the climate conferences that I was going to in 2021, 2022, we were given tests and encouraged to test every single day. Some places required you to take a photograph of your test to submit it before you could get into a space. And so this is maybe another tool that we could have used better than we have been. It's kind of sad that we don't even have the ability to get tests at this point in time. Um, a couple caveats to that. Um, I think, rightly points out that the test, trace, isolate efforts were a complete failure during the COVID pandemic because of the asymptomatic spread. There was never the ability to actually follow cases back to their origin or warn people explicitly. And so there was a ton of effort put into this test, trace, and isolate efforts that was probably completely worthless. The other thing that he argues, and I think I'm a half believer in, is that travel restrictions are not very useful. Now, his argument is that for, say, the Ebola outbreak that happened in 2012, the United States put a blanket travel restriction on all of sub-Saharan Africa, said that nobody could travel to the United States from that. And I think he rightfully argues that that didn't actually have any impact on transmission. It was considered racist. It was overkill. The caveat to that would be that in Wuhan in 2020, there was essentially no effort to restrict travel out of that area in January and February. And had that been put in place from Wuhan, you could argue that the transmission out of that space would have been much slower. The other caveat to that is there were places in the world that had very, very good effective COVID zero policies that were necessitated by travel restrictions. And the places that I think of is Atlantic Canada in my own country, and New Zealand, and Australia. And I'm just focusing on those because they're Western, and I come from a Western background. So so in those countries, you actually had quarantines for two weeks when you entered into those spaces. It's not that you couldn't go there; you just had some robust travel restrictions, some policies that you had to follow when you arrived. Again, I'm just a really big believer in respiratory masks. I could imagine a scenario where you wear a button saying, "I'm on day 7 of my return back to Australia, and that's why I'm wearing my mask, and I'm going to wear this respirator mask for 2 weeks, and then I'm going to take it off." And that way you could participate in things. You wouldn't have to sit in your hotel room for 2 weeks. So, the final aspect of this is I do think that if you have local transmission above a certain rate, then the travel restrictions are kind of useless. So there were times where, like, we had couldn't travel between my province, Alberta, and British Columbia for months and months and months on end. Yet there was rampant COVID transmission on either side of that border from people transmitting it from one person to the other. And therefore, in those scenarios, say if we just pick a number, if 50% of all new cases are found to have come endogenously from your own jurisdiction, why even have a travel restriction? So we could have done that in a much better nuanced fashion. Medications and vaccines are a full chapter. I am absolutely no expert on these. I do think it's important to be aware that this is a kind of a middle stage part of the pandemic, right? Um, none of these vaccines or medications were available for the first year of the pandemic, and that's when, in particular, those non-pharmaceutical interventions are key until these come into place. Um, and even, in a perfect world, the society puts a lot of energy and effort into getting these medications and vaccines created. Um, and once they're out, they're either sterilizing vaccines or have 100% treatment success, and therefore we can relax things at that time. For the SARS-CoV-2 pandemic, that was never the case. The vaccines were never sterilizing, and the medications were never 100% effective, and were never available to the majority of the population. And therefore, at least in that pandemic, they could not be relied to supplant non-pharmaceutical interventions. And I think we can all look back at the moment where the United States CDC said, if you've been vaccinated, you can take off your mask. Um, as a moment of kind of science failure, because not only um, was that not accurate, you could still get COVID and get long COVID and even die from COVID. Have you been vaccinated? But also, there was no way of telling who was vaccinated or not vaccinated. So therefore, um, telling people to take off their mask if they're vaccinated wasn't a particularly useful policy, and we need to avoid those kind of missteps. And I think, in the second session today, we're going to talk a lot about trust, and I think that was a real moment of loss of trust in science for the population when they were told, if you take off your mask, you're not going to get COVID. And then people got COVID. And they're like, well, what are you telling me this for if that's the case? That's just an obvious lie. All right. So now we're going to get into policy and the enactment of some of these policies. So, obviously, when you have a tool, you can enforce that through mandates. And at the beginning of the pandemic, March 17th, basically that was the start of quote unquote the lockdown that happened across most of North America and the Western world, where everybody just stayed in their house. And then there was also mask mandates that were coming on and off. And so I had a long conversation with Dr. Osterholm about this and the idea of having thresholds, because what I saw in my jurisdiction is a huge amount of arbitrariness that went into when these mandates come into place and when they came off. It was kind of a vibe thing. Okay, we have exponential growth, but it's not too bad yet. Why should we put things in place at this point? And then on the other side of things, you had an incentive to take things off so early. Okay, we've had a couple of weeks of decreasing transmission, therefore we can take it off, and that often went because the non-pharmaceutical interventions work well. It went to wild swings in transmission, and not really based on anything other than vibes. So here's what I think we should be doing. We should be putting in triggers in place where that are preset and that allow society to figure out where they're at on the implementation of mandates and where they're at for the removal of mandates. And if we make those triggers publicly available and watchable, then as a society, we as a whole can work together. I bet you with that knowledge, we could even avoid some mandates because people go, oh, we're really approaching the moment where a mask mandate is important. Therefore, we need to alter our behaviors. Oh, we're reaching the point where a lockdown is important, and therefore we need to alter our behaviors. And so, if we look at kind of these escalating public health measures, there's kind of four that I was imagining. There's maybe other levels to this, but there's respirator mask recommendations, respirator mask mandates, closure of public events and restaurants, and then closure of schools and non-essential workspaces, which is essentially where we were in March of 2020. That's a huge escalating uh, series of measures. And, you know, you'd be doing the mask recommendations at a very different level than closure of schools and non-essential workspaces. So the next question would be, well, what would those triggers be? And I don't actually know the answer to that. We would have to have that as a discussion. It could be just simple cases. Okay. We have, 1,000 cases in my city. Therefore, we're going to put in mask recommendations. We have 10,000. Okay, there we're going to put in mandates. We have 100,000 cases, but you could pick those preset levels for cases, percent positivity, hospitalizations, deaths, or you could use the wastewater surveillance, which is de vogue nowadays. So how would this work in practice? Well, this is a screenshot from our Alberta percent positivity, and I've put the percent positivity rate at I was aiming for 7%. I think we're at 7%. Um, the the y-axis on the right is a bit off, but I think it's at 7% there. So that you can see that as that level was dropping in April of 20 or in June of 2023, we would have hit a trigger, removing a mandate, and then a few weeks later, unfortunately not that long later in the summer, it starts to go up again, and then that trigger would re-implement mask mandates, and then you could watch it come down again and go, oh, we're only a few weeks away, and yes, in April of 2024 we can remove the mask mandates, and then oh no, now it's going back up again. And so by having that preset level that everybody can watch, everybody can be a part of, they can work towards that communal goal. Um, feel like I had something else to say there, but I'm forgetting it. So the last thing I want to talk about is communication. Um, I was recurrently distraught about the communication coming from both our public health officials and our politicians. And when I was doing my engagement, I was I really made an effort to be brutally honest all the time. And partly is this quote: trust takes years to build, seconds to break, and forever to repair. And I think we're dealing with that now in our many of our societies' inability um, to trust science at this point, and to trust politicians, because there were multiple uh, events, in particular airborne transmission. In particular, some of these were almost through this wave, even though there was no evidence of that. Um, that 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 trust was broken. I always kind of jokingly posited that there should be an equivalent to baseball cards for pundits, where their predictions and their assertions were judged, and people could see how many times they got things wrong. Because even now, I see people who got the pandemic, the basics of the pandemic wrong multiple times, still coming on television and still speaking to media. And the media doesn't seem to care whether the pundits that they have on are trustworthy. They care more about the credentials that that person brings and how available they are. And so if they can email them and get them on TV in half an hour, then they get to be on, especially if they're an infectious disease doctor. I'm not saying I got it right all the time, but I bet you my baseball card would be okay. So I think one of the problems with this is this concept of elite panic. Um, I don't know if everyone has heard this concept, but it's the idea that in a disaster, the elites worry mostly about whether the population is going to rise up and overthrow them. And so they will often lie, and they'll often put in place um, uh, overreact in many ways. I think the most recent example, aside from the pandemic, would have been the Hurricane Katrina event in the United States, where generally what happens in a disaster like that, instead of people looting and burning and destroying society, they come together and they actually work together as a team. They help each other. And that has been shown recurrently through disaster after disaster after disaster that people mostly want to help each other. They don't want to destroy each other. But the elites feel like there's this kind of zero-sum game where people are going to try and use this moment to destroy. And it's been shown wrong over and over and over again. And so I do think that's maybe part of why the airborne fallacy or the airborne mistake occurred, was this idea that if we actually say it's airborne, people won't be able to deal with that truth. This is an article I found in preparing for this, and it's a great title. Just be honest with us: a quantitative analysis of Canadians' public trust during the COVID-19 pandemic. And this is from the abstract. Changes in trust experienced by participants were anchored in experts' ability to communicate reliable information. Participants further emphasized the need for transparent and consistent messaging, particularly from the Government of Canada, to rebuild lost trust and prepare for future public health crises. People know when they're being lied to. People react poorly when they found out they've been gaslit. I think public health needs to really look back on the pandemic and some of their communications and figure out why they said the things they said and whether it was useful or not. And that's really the end of the formal part, but I'm really excited to have a conversation about all of these. It's very likely that Michael or myself have gotten things wrong, or there are nuances here, or they're like, Joe, you forgot about this, you forgot about that. So this is the time to have that conversation. And then I really want, and Yanir, I'm sure, and Frank are going to steer us for that last 15 minutes. If this is a robust way forward, how do we ensure it doesn't just fall by the wayside and is never implemented should we have or when we have another event like the SARS pandemic? I see one hand up already, Yanir. You are
Yes,
ready to go.
I'm gonna take the prerogative and make one comment, which is that I agree with almost everything Joe has said, but I do want to gently push back on the first assumption he made, that there's actually an inherent trade-off between public health and economics. And this is actually something that has been very widespread in the public health community. The thing is, this is actually why we need good multidisciplinary work, because the economists don't agree. And in fact, IMF, among other economists, did very clear analysis early that there was no trade-off, that the early action to stop the pandemic would have been much better both for public health and economics. And this is one of the fundamental assumptions that I think really needs to be changed when not only we prepare for the next pandemic specifically, but when we think about the whole nature of how exponential growth works. And Joe, I'm sure we'll have other times to talk about this. If you want to make comment on it, that's great. But I just wanted to make that comment so that it's available. Okay.
100%. I agree with you. And there was really good, robust economic analysis that talked about that. Um, I guess my thought is, and we haven't done this, so it's a bit of a thought experiment. But if we had universal respiratory mask use, could we have had a more functional early approach to the pandemic? Could we have had safe schools um, with that in place? And
And
could we have had um, more engagement? Would I go to a hockey game at a time of mid to moderate transmission if I knew that everybody in that space was wearing a respirator mask and there was good ventilation?
I think that
Maybe I would.
the different model really, when you think about exponential growth, is early action is what matters. And the point about that means that it actually would have taken a month if indeed people had the right things, masks and respirators and air, understanding of airborne and so on. But the point is that even if you don't know, doing the maximum of what you can do to stop transmission actually pays off because you can do a lot. You can bend over backwards for a month. It's when you don't do it well. If you do it part way, if you cut corners because you want to do some things early, be clear that this is one of the things that is requires some additional thought. I don't want to make it trivial. It does require additional thought, but the point is that understanding that you can stop something quickly if you go all out is very different than an approach of trying to make trade-offs. That's all I wanted to say.
And I totally agree. And I think we all agree that early in the pandemic, we needed to all sit in our basements and try and figure out what the heck to do. Um, I guess the next question is when you allow people out of the basements.
And
Uh,
that's
and
that's
and
exactly right. Yeah.
and so that's why that idea of preset triggers or thresholds is there so that it's not arbitrary. So it's not when it's convenient for the politicians, it's convenient for the restaurateurs. It's when the evidence um, suggests it's safe and everybody knows that. And so we're all pushing towards the same goals.
Let me make one more comment about this. Michael Osterholm, when he was on the Biden committee, advocated for actually this approach. When they didn't agree to it, when Biden came into office and said, no, we're not going to do that, then is when he accepted this economic, the political will story. But he knows about how to stop pandemics. He was involved globally. And the fact that he knows about it was guiding his recommendations at that time.
Yeah.
Um,
And I'll just say one more thing and a part of that. One of the criticisms which may come up in this conversation is that in some podcast, he said maybe that trigger should be instead of early in the pandemic, it should be when your hospital capacity hits 95%. And he got a lot of criticism about that. It's not in the book. So I want to emphasize it's not in the book. And I don't know if that was just a comment that he threw off, but I think we all know that if exponential growth means like a doubling in 7 days, when you're at 95% capacity, that means in 7 days you're double capacity. And so I will go back to what you're saying. Early action is always better in exponential growth. Um, but again, that preset. Oh, I remember I was looking at that slide. Can I go back to that if you guys are okay, please? I just want to go back to one thing. Um, because I remember what I was going to say. Remember this slide where I was saying for seven, it could be percent positivity that the trigger is set at 7%, and I just randomly picked that up because it looked good in the in the slide. The reason why this isn't important is because if you are going for COVID zero, if you are Nova Scotia or New Zealand, you could set that preset trigger at 0.5%,
it's
right?
actually it's actually the trigger is actually in the number, not in the percent. That's what is really key, and it is
Well,
by
that's why this is just an
yeah.
example. We could put set out of cases or hospitalizations, or whatever. But in a place where you're aiming for COVID zero, you may want, okay, now we have innate transmission. We have 10 cases in Auckland. Let's tamp it down back to zero so we can go back to living a society where masks aren't required. And so this trigger would be different for different places and different scenarios.
Yeah, let's go ahead and talk, Jeffrey, please.
Well, thank you very much. Joe, this was a privilege to hear a fantastic recitation of the history with a good constructive recommendation. I'm very grateful for hearing it. I would like to expand the conversation a little bit and hope people listening will consider that I'm going to add two Venn circles to the diagram that Joe outlined as the big COVID protection circle. And my first thought comes from the study of economics. And while I go into it, I didn't hear the same thing that Yanir heard in your discussion. I think public health efforts are anti-capitalist, anti-neoliberalism economics, and confronted head on with the failure of its ideology. And that's where the clash between public health and economics happens, not on productivity or GDP or impaired circulation. To go back to my point, if you look at economics, economics was built on the tower of rational choice, the rational man, what would they do in supply and demand situations? And it was Joe Stiglitz who brought up, if you will, animal spirits. And I listened to the conversation that you gave and the framing that you used, which was, if you will, rational man framing. And I think that we have to expand the conversation to have another Venn circle that recognizes that both on the individual, on the family, on the community, and on the collective national and international level, the response to pandemics is irrational. If that's when you go back to 1918 and say we buried it, that was an irrational response to a great threat. It was too scary, too unknown, too impossible to deal with, and we put it behind us. I happen to work in child abuse and neglect, and we have here a very common situation called dissociation, where people who have uh, extremely been stressed and threatened, their mind goes away into another place and they have no memory of the harms that were done. And they later in their life are able to tune out and be weird and like have non-medical seizures or collapse or very bizarre symptoms, but their body dissociates from reality. And I say there's a collective analogy to this, which is analogous to Stieglitz's animal spirits, and that is a big, big, big contribution to this dynamic, which needs its own explanation to supplement yours. And in ending, I'd say there's another circle that I would add, which is ideology and politics. And you have to look at the irony and you do not explain why the population has trusted Trump when everything he did except the vaccine with regard to COVID was total cowpucky. And where did that trust come from? And why did he get reelected in the context of that public policy behavior? So I think the expansion of the paradigm will lead to a better understanding and better outcomes. Thank you.
Thanks for that, Jeff. I have nothing to reply. I agree with everything you said. Sunil,
Go ahead. Yeah. If you want to call on people, you're welcome to do that, Joe.
I'm just going through the
Thanks, Joe. It
hand.
was, yes. Thanks, Joe. It was a great presentation. But I just have two questions. One, when we talk of the next pandemic, are we talking of an inevitability that the next pandemic is due to happen? We can't stop it. One. Two, and does this concept of triggers actually feed into that inevitability? We understand or we say that this is 5%, we accept it, and 5% of deaths is acceptable, 5% of infections are acceptable. I understand triggers do work very well in non-communicable disease settings, a stroke, and acute coronary syndrome. But I am very worried about the fact that triggers may not actually work in infectious disease settings. So once your numbers start swelling, once they go beyond one, the chance of it growing exponentially will always be there. So that's how I see it.
Yeah, I guess I would say that we know that the non-pharmaceutical interventions worked. We know because every time we implemented them, things went down. And so the idea behind the triggers is to implement those non-pharmaceutical interventions and that there are and acknowledging that there are impacts to those non-pharmaceutical interventions. And therefore we need to have a more scientific method of deciding when they get implemented and when they don't. And you could argue that at the beginning of a pandemic, if the goal is COVID zero, then zero is the trigger. That uh, that didn't happen in our. We never tried to do COVID zero in the Western world, and arguably the reason why China failed is because the Western world failed as well. So they were inevitably going to be overwhelmed. But also, I don't think that doing exactly what China did uh, would have been good for our society either. Might have been good for deaths. It might have been good for long COVID. But they did that for 4 years, and it was deemed untenable at the end of it. Um, I don't think we still know what the end result was, and I think COVID zero uh, is a noble goal and could have been implemented in a non-authoritarian fashion and certainly was in New Zealand and Australia. Those are the models I think I would be looking at rather than China. So we can 100% win any battle if we all sit in our basements forever. And arguably, and this is a discussion we could have now, arguably you will never get COVID again if you wear a mask for the rest of your life. Is that really where we think society is capable of doing, or is willing to do? So, I mean, those are the questions. I see the next hand up is Nicholas.
Hi, Joe. Yeah, so just a couple of thoughts actually on this. So the first one with regard to more of a concrete thought regarding the positivity rate. Uh, I- Based on some discussions or relatively sort of recent sort of findings with Tara Moriarty, she was mentioning that the sensitivity of the test seems to be decreasing or changing with the sort of the evolution of the viruses. So I suppose that the positivity rate would have to be then adapted as in accordance with the sensitivity of the tests. So in other words, a 7% when the tests are very reliable may not necessarily mean a 7% with the tests are less reliable. Maybe she may be able to provide more information there on that. Um, and the second comment I think is sort of interesting, where you said the sort of the rift between public health and the public's confidence in public health, where the population started to lose faith in the government. Um, Here, I think what's interesting is that obviously then a lot of people turn towards influencers and social media in order to get their information, right? I mean, either those that were very much sort of pro mitigation, or those that were much more open to people getting infected. And I think then it sort of put an unfair burden on a lot of scientists and doctors who decided to share information, but at the same time became sort of public figureheads, right? I mean, stakeholders on either side. And as a result, it created almost like local social media celebrities for people that were either supporting either position. Oftentimes, if you're trained as a scientist or a doctor, you're not trained to be a sort of a public figure. And also, when you're posting on social media, you're not like like a public figure like Theresa Tam, who you only see the facets you want to see, which is when she disseminates public health information. You're sharing your whole life with people online. So in other words, is that it creates an interesting dichotomy between you being the source of information, taking on the role of public health, but then also being exposed to everything else that you do. So I think that there was something there as well where it created an interesting situation where it created these sort of micro silos of people that became source of information online, but at the same time, as they became these sources of almost, they developed this sort of little celebrity status because of the information they're presented. There was also an unfair burden put on them because they themselves were then asked to take on their backs all the weight of public health, and also to every single aspect of their life was also scrutinized. So it's interesting. So the comment I'm sort of making on this is 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 uh, is, what exactly happens in that situation where you have all these people that then become the sources of information, and they become really what people rely upon, but they themselves don't necessarily have the training necessarily to communicate all the time to the population, as the population sort of turns more and more toward to them to gather their information as to how they should live their lives with respect to these incidents. So
Yeah, thanks for that, Nicholas. I'll just talk back to your first comment. and that is that I in no way was suggesting that percent positivity was the right measure or that 7% was the right threshold. I just made that up because I gave you, 5 different things you could measure, which include hospitalizations, wastewater cases, and saying that I don't know what the right measurement to use is, and I don't know what the right trigger is, and I suspect that's different for different places. I'm suggesting that we, as a society, figure out what those are. And I was just using that as an example because I wanted to have a graph and said this is how it would work in
Joe,
practice.
Joe, I just want to mention we have 2 more hands raised, and I think then we should go into planning next steps because
Sounds
we're
good.
the next steps in the last 15 minutes.
I just want to quickly reply to one comment in the chat. I got COVID while wearing a respirator mask, so wearing the mask the rest of your life doesn't protect you either. That is absolutely true. I do think in the situation where there is a respirator mask mandate, where wearers like source control and PPE, that's in my mind, a very safe situation. And that's granted, we don't have any examples of that because, as far as I know, no society put in place a respirator mask mandate. So that's a bit of a thought experiment. But I do think it is different if everybody's wearing a mask than if just the person being protected is wearing a mask. Mark and then Dorothy.
Yeah, thanks so much. Great presentation, great conversation. My question is this: does air cleaned to the level of the ASHRAE 241 standard for control of infectious aerosols allow for relatively safe one-way masking? This relates to the question you just had. For those who want to stay, want a near zero chance of catching COVID in that space, I've often used ASHRAE 241 as an advocacy target goal, but wondered kind of what your reflection was on that. Thanks.
Yeah, I'm not an engineer, so I don't want to talk out of my space. I would say that a well-fitted respirator mask, whether that's elastomeric or a disposable one, is a pretty effective tool, but not 100%. And I think, particularly when I think of my colleagues in healthcare, the times that they've gotten sick despite wearing a surgical mask was when they were in high risk situations. So I'll give you one situation where one nurse was caring for 2 COVID patients in the same room that were both very sick, on high flow oxygen. And she was in that space for 30 minutes at a time. I have another colleague who got sick wearing a surgical mask, not a respirator mask, while he was suturing up a little kid's face who had asymptomatic COVID. And he was, of course, in that kid's face. And so you wouldn't expect in either of those situations, think of a cigarette smoke. If you have 2 smokers in a room, it's hard to clear the room of that smoke. If you have 5 smokers in a room, it's really hard to clear smoke from that room. And if you're right next to that smoker, it's going to be really hard to clear the smoke from your face. So that cigarette smoking analogy is a really useful tool in my mind for establishing risk. Dorothy?
Thanks, Joe. And I appreciate all you've been doing from Masks for Canada onwards. I wanted to make a sort of a combination of points and as quickly as I can and a question or two. So I'm a hygienist. So for me, as I've said to other people, respirators are sort of the last thing that we want to do in terms of protecting people. That's our training. As a hygienist, another hygienist reminded me, it's a sign of failure. So for some of us, so I think more about other things as well as respirators. And as I'm somebody who wears a respirator pretty regularly still these days. And so this whole idea of layers and not just wearing respirators, but trying to do things with the air, the number of people in it, that kind of thing. Trying to see how do you incorporate that into the kind of thing that you're talking about. And the other thing is that I didn't hear you talk about, I mean, you're very good, thank you, at saying you're not an engineer and et cetera. There are people out there from different disciplines that have been, from whom I've learned a lot in this pandemic. And so I really think that given that the public health folks, the IPAC folks, their training, frankly, doesn't cover any of this stuff that they have sort of self-declared experts on. part of our job is to figure out how to get those multidisciplinary voices being the ones that are doing the communicating, or at least being part of the decision making. In some ways, I don't care who's doing the communicating if they're trustworthy, but they need to know what they're talking about, and have the right messages. And then my last is sort of a question is, one of the things you reminded me about at the very beginning was, what's the difference between the Naylor report and Campbell's report, and why is that important?
I'm going to skip the last question because I don't know, because I haven't read them full. I know that PHAC came out of the Canada
Yeah,
report,
but
and
it
cautionary
wasn't.
principle respirators came
Yeah,
out of the Campbell report. If I can speak to the first part, and you're speaking to the hierarchy of controls, which is like, it's almost, I would propose, dogma in the occupational health and safety community.
and in fact, I
And I'm
don't use
always
that term.
careful of dogma.
Mhm.
And I would say I don't know of any engineering controls that can protect against near field transmission.
The-
And then I think near field transmission is a huge component of what goes on. And also the engineering controls take a while. So maybe we start now and we prepare for the next pandemic, and therefore everything's in place when the next pandemic comes. But in March of 2020, none of our indoor spaces were ASHRAE 241, right? None of them. Many of them aren't now. So if that's the case, we can't rely on those engineering controls to protect us. And really, when you think about it, a mask is wearing a filter on your face. And if every single molecule of air passes through that mask, um, on the way into your lungs, and the transmission is predominantly airborne and not from touching your eye when you touch your mask, which I think is ridiculous. But if that's the case, then that mask should be pretty darn good for everybody in most situations.
yeah,
Not perfect, nothing's perfect, and I agree with you. The Swiss cheese model is great, but as far as I need to enter an unsafe space, I need to protect myself now.
mhm,
That's my go-to.
yeah. And I'm
And
just trying to say
Dorothy,
that
Dorothy, yeah,
that the emphasis on the air needs to go beyond respirators in terms of our goals. That's I think, is my main point there.
thanks, Dorothy. Joe, you have still the floor. It's a question of how you would like to discuss next steps. Because I think that the overall strategy that you've raised of creating a systematic approach and not coming at it by surprise at the last minute is essential. So the question is, how would you like to proceed with some next steps in terms of developing this further?
Yeah, and as I said at the beginning, I think that the big one, the book, isn't a Bible that we should be thumping, but it may be a good tool that if we, if you ran into somebody's like, I don't know how we're going to approach this pandemic, you could say, read this book. This is going to help you. This is going to help frame your question. So maybe we need to proselytize that a little bit. I do think the two caveats that I would put in there is that the triggers need to be more explicit, and school protection is not in there. So I really spent a lot of time on that in my talk as being caveats to the Bible, the big one being a Bible. But other than that, I think it's a pretty good next step. I do think an inquiry is probably unlikely to happen in the United States or Canada. I did see, I kind of breezed through the chat. Somebody was mentioning that even though I was saying that the UK seems to be doing a good job, there's not a feeling in the UK that it's actually going to make any change. And so, and obviously the Campbell inquiry and the Naylor inquiry in Canada did not make change. So maybe my dream of having an inquiry fix things is not an accurate dream. But I guess that's why I put it open to the crowd. Maybe even if you don't think that what I've presented is the right way forward, what is the right way forward, and how do we not let this fall by the wayside? This is the solutions part. And the fact that not everybody's hand is going up saying, I've got a solution, means that this is really
I think,
hard.
I think part of the challenge is that when things don't work well, the challenge is to figure out how to disentangle what was possible and what might have been possible, how it will apply under different circumstances that are not the present time. The question is, if there are people who would like to engage with this subject, which is ultimately where we have to go. And many people are really thinking about this subject, even though there's not enough systematic conversations about it. The question is, where can we create systematic next step conversations? And I do think that Joe presented important ideas that really should be incorporated in any plan going forward. And details or specifics are not the issue right now. The issue is there's an importance to this as a systematic approach. Dorothy, if you'd like to go ahead, please.
Yeah, thanks. Joe, you know that the Canadian Aerosol Transmission Coalition is working on what they're now calling 6 pillars of pandemic planning. And so one of the things that might be helpful is for some kind of collaboration amongst people here with the folks that are working on that. I saw Lynn Filiatro's name coming up. She's chairing the next coalition meeting and is involved in working
And
on
it's here. Yeah.
those. But that's one effort that's being made, that's going on, that it just seems to me to be silly to have it separate from things that people here may think about doing. I'm not saying that people can't be doing other things, but there's some way to collaborate around that.
Lynn, can you come on for a moment? We have a couple of minutes.
Yep. Can you see me? Hello.
We can't see you, but we can hear you. Now we can see you.
Okay. All right. Yeah, I, I think, I don't have a solution, but I don't think an inquiry solves the problem. And the UK, if you look at the CATA group, which is the equivalent of the Canadian Aerosol Coalition in the UK, they sent a letter recently stating nothing has changed. So IPC in NHS is still wash your hands and wear a useless, next to useless mask, or a mask that doesn't work in high risk situation. So for me, the solution is really bottom up. And I guess it's what the WHN and the Canadian Aerosol Coalition are trying to do. I do not agree with the triggers, as I put in the chat. First of all, there's no more capacity of healthcare is running in Canada at 95% on a good day. So if you want to trigger that, you'd be triggering all the time. And so, COVID has created increased demand and is accelerating chronic disease and aging. And so we're only going to see more and more unraveling or inability to meet demand. So my strategy has been to try to write op-eds and get to what bugs me, but also what the public is starting to realize, particularly parents with kids. The kids are sick all the time. We're into RSV now. So if we can get them on board to say, we need fucking clean air in schools, because clearly my kids are sick all the time. And if it's about commonality, everybody wants their kids learning in school, and a sick kid doesn't learn, and a sick teacher can't teach. And teachers are third in line with the highest rate of long COVID. So to me, is find the pain points and get people to argue for what we want. But it means a different message for different people.
Joe, do you want to pick up on this? We can take another couple of minutes, maybe 3. Go ahead.
Yeah, I'll just mention that this wasn't a suggestion for what we should be doing now. That's a whole other separate discussion. And I think Lynn and I would have, again, a Venn diagram of circles rather than 2 overlapping circles, which is, that we need to clean the air right now and make our hospitals safer and our schools safer. I 100% agree. This discussion was really about a future severe pandemic event and how we would approach that. So I just want to be clear on that.
Let me just say something. This as a project, which is defining process and protocols in response for pandemics or for current circumstances, all of this is well justified as an essential part of society. And I do think that we are in agreement, at least I think, that we are not better prepared than we were before. And this whole raises the question about how do we move forward. We do have this workshop as a project on the agenda for continued engagement. And so if people would like to participate in this, surely you can drop your name in the chat or you can respond to the email that's been sent out with a link to all the project. But I do think that this is super important moving forward. And Joe, please have the last word.
I just want to thank you for listening to me. As I say, I don't have any special expertise in this other than thinking about it way too much. And I just hope that we can not go back to pretending that this will never happen again, because um, forewarned is forearmed, and planning is an extremely useful tool. So whatever we can do to keep this discussion alive, I think is an important one. And I'm not saying I have the right answers. I'm just saying we need to create some answers.